And the mother complained that the child has developmental delay since birth. So there was some problem since birth. So there was a developmental delay, and he had 5 to 6 episodes in the last year, and yesterday was the recent episode. So, so baby achieved neck control and was able to turn about on bed at 6 to 7 months. Not able to creep, crawl, or sit or stand without support, and inability to walk as well. Unable to drink from cup, scribble, build blocks. Baby recognizes mother and smiles, also smiles and sees mirror image, which is achieved at 9 months. Baby can only say mama and papa. Baby laughs out loud when happy and responds by smiling when hears his name. And baby is able to make eye contact with the mother. Baby is able to make eye contact with mother. No regression of above acquired skills. So there is no regression. Whatever milestones he has achieved were delayed, but they are still present. And no behavior abnormalities. Sleep is disturbed. History of occasional inconsolable cry. And mother noticed deviation of left side of mouth during feeding at 6 months of age. There is no drooping of eyelids. Mother also complains of oral regurgitation of feeds, coughing during eating, associated with drooling of saliva. And baby had 5 to 6 episodes of respiratory tract infections in the past 1.5 years and treated at nearby nursing homes. So he had repeated history of repeated respiratory tract infections. And mother also complains of posture of movements more in the lower limb since birth, and the baby has a crossed leg posture while lying on the bed, 1.5 years of age. So this shows that crossed leg, other words we call seizuring. And no other abnormal movements noted, no bowel or bladder movements, abnormalities, and no progression of opposite noted. So this was in detail about history of presenting illness. So baby had developmental delay since birth, and there was no regression of the attained milestones, and he had history of recurrent respiratory tract infections also. And according to the history, mother was saying that lower limbs were there was more involved. So with this history of presenting illness and chief complaints, we will go for antenatal history. So antenatal history, it was a registered case. Number of ANC visits 6, and the first trimester mother had received iron and folic acid, and the datic scan was done, and there was no fever with rash, there was no urinary tract infection, no history of radiation exposure or drug intake. So why these all are important? So what? So every question we ask to the mother or whatever mother tells, so we should retrogradely think. So why iron and folic acid? So iron and folic acid, iron yes is again for anemia. Folic acid plus child can get a neural tube defect. And scans, whether there was any abnormality identified in scans only, or were they done inappropriately. And any history of fever with rash. Yes, again fever with rash in pregnancy that in first trimester can be a TARS infections. So any history of radiation exposure or drug intake, yes, because there are some teratogenic drugs. So mother has received any of those teratogenic drugs, and is there any relevant to the current condition of the child? Similarly, radiation. So radiation is also dangerous to the mother, especially pregnant woman. So especially in the first trimester. So is it any relevant to the child's current status? So this is how we need to take the history. So detail in the first trimester, again in the second trimester, yes, when was the quickening? Is it normally at, as usual at 5th month, or is it delayed? And whether the 2 doses of whether 2 doses of TT were taken, and was the anomaly scan done? If so, how was it? And OGTT, this is glucose oral glucose tolerance test, because diabetes again has some teratogenic effects on the child. So whether the mother sugar levels are normal or were they severe high. So all these things you need to ask and try to correlate with the current condition of the child. So So no history of headache, blurring of vision, fetal edema. Again, these are the we are trying to note any PIH, that is pregnancy induced hypertension, any preeclampsia or eclampsia. कहानियां करके आते हो पूरा सामान आके तो पूरा महंगा पड़ेगा अरे एक बार बोलो तो भी आप कॉपी करके आ रहे हो and third trimester how was the growth scan
क्या सात सौ लेकर
how was the growth scan? So whether the growth was normal, whether the fetal movements were pursued well, was there any history of bleeding PV or leaking PV, and was there any history of medullary infections or premature rupture of membranes? So again we need to correlate each and everything with the current status. The PROM means possibilities of neonatal sepsis, thereby meningitis and thereby neural complications, and again bleeding PV, leaking PV also similarly any scope of infection. So these are the things you need to ask in the third trimester. So next after antenatal, now coming to labor history. So how was the delivery? So it was a full term normal vaginal delivery, and it was done. So it was done at a hospital, and was no use of any instruments, and the liquor was clear. And neonatal history, admitted to NSU immediately after birth, as baby did not cry at birth, and one episode of seizures as told to the mother by doctor. So child had seizures immediately after on day 1 of life. So for that, baby was in NICU and admitted in NICU for a period of 2 weeks. Baby fed with expressed milk. Baby discharged at 3 weeks of age. So baby was there for 2 weeks and discharged at 3 weeks of age. So this is very significant. Whereas if you take so far antenatal history, everything was normal for second, third trimester. But yes, natal history during delivery there was some problem. So baby did not cry at birth. So for which baby was admitted to ICU and baby had seizures and baby had a prolonged stay. 2 weeks is significant enough. So for baby was 2 weeks and baby was fed with expressed milk, and then baby was discharged at 3 weeks of age, and there was no history of any neonatal jaundice. So after this natal history, so which was very significant, we'll come to developmental history. So how was the development? So we'll discuss in 4 domains: gross motor, fine, social, and language. So gross motor. So when was the head control? Head control was attended 6 months, which was supposed to be attended 3 months. So that means it is delayed. And rolling over 8 months, which was supposed to be attended 6 months. And sitting with support 12 months. Sits without support, so far no. So these are the gross motor dominants. If you see it is developmental delay is there if you come to gross motor. Then coming to fine motor, coming to hand regard. So 6 months usually, which is at 3 months. So 6 months there was hand regard, and bidextrous grasp, which is at 7 months. Usually it is at 4 months, but child has attended 7 months. And coming to palmar grasp, 8 months compared to 6 months of normal. And the transfer of objects from one hand to other, 9 months compared to 7 months of normal. And immature pincer grasp, 14 months, which usually we see at 9 months. And mature pincer grasp is usually at 12 months, but this baby has attained at 18 months. And drinking from cup, so far no. Still the child has to be fed by the mother, no parents. So coming to the social smile, usually any child will social smile, have a smile by 2 months, but this child at 4 months. And recognize mother at 3 months instead of 2 months, and a mirror play 9 months instead of 6 months. And ask for objects by pointing, still so far no. The child is 2.5 years, which would have acquired by 3 months. And language vocalizes at 3 months, going by 4 months, which was supposed to be there by 2 months. And laughing out loud is at 6 months instead of 4 months. And monosyllables 11 months instead of 6 months. And bisyllables 14 months instead of 9 months. And visual fixation is at 5 weeks. So this is if you see here, so child is delayed in all aspects. Gross motor, yes, it was delayed at every aspect. Fine motor, yes, delayed. Social, it was delayed. Language, it is delayed. So all the domains were delayed since birth. So there was a global developmental delay. So this category, it is a global developmental delay with a, so far there was only significant natal history. So coming next history is immunization history. So mother was telling that child was immunized as per age. So child all vaccines up to 2.5 years child has received. Next after immunization history, neutral history. So child was exclusively breastfed for 6 months, yes, as per the requirement, and weaning was started at 7 months, and with 3 to 4 breastfeeds per day. So at 7th month weaning was started, and 3 to 4 breastfeeds per day were still continued, and calories consumed were 1220, and proteins were 19.2 grams. And past history, yes, we have already told you that there was a history of recurrent respiratory tract infections. Around 5 to 6 episodes were there in the last 1.5 years, for which child was admitted at a local hospital and treated with IV antibiotics. And the treatment history, currently not on any medication. Family history, no similar complaints in the family, and no history of early neonatal deaths. So no other family member has similar problems, and no history of any neonatal deaths. So with this we have done with our history. So if you take history, if you summarize the history, so he was a 2.5 years old boy child who was a product of non-consanguineous marriage, and who was first in birth order, and who had normal antenatal history, and who had significant birth history, that is baby did not cry at birth, for which baby was prolonged NICU stay for almost 2 weeks, followed by discharge, and later on there was a global developmental delay with normal family history, and past history of repeated respiratory tract infections. So this is in detail if you summarize the history of the patient. So with this history, we'll go to the examination. So how was the baby? So baby was lying down comfortably with crossed legs. So response to verbal commands. And coming to vitals, temperature is normal, respiratory 20, which is again normal, heartbeat of 120, this is also normal, and blood pressure of 170, 100 by 170. So vitals were normal. And weight 11.5 kgs, so average weight, reasonably good weight. Height 89 centimeters, head circumference 45 centimeters, chest circumference 43, and middle of circumference 12.5 centimeters. So if you see head circumference decreased, it is only 45 centimeters. So head to toe examination, yes, head microcephaly, fontanelles are closed, eyes are normal, ears are normal, neck is normal, palate is normal, chest normal, umbilicus is normal, genitals normal, extremities are normal, and skin is normal. So complete head to toe. Only one positive finding, that is there is microcephaly. So coming to systemic examination, as this is a CNS case, so far we have understood. So first we'll start with CNS examination. So CNS examination, in that again cranial nerves. So facial nerve, there is deviation of mouth to the left while smelling, and there is absence of nasolabial fold on the left side. Coming to the motor system, bulk, tone, and resistance to passive movement. So how is the bulk? Again upper limb, left upper limb, right upper limb, left upper limb, and then lower limbs, right and left. So bulk is normal in both the upper limbs, and there is wasting of muscles in both the lower limbs. And coming to tone, tone is normal in the upper limbs, and tone is stiff, that is increased in the lower limbs. And resistance to passive movement, yes, present in the upper limbs, and in lower limbs it is increased significantly. So in the motor examination, it contains of 2 to 3 domains: bulk, tone, and resistance to passive movements. So all the three domains are normal in the upper limbs, both right and left upper limbs. But if you see lower limbs, both right and left, they are deranged. So there is wasting, there is stiffness, and there is increased tone, increased resistance to the passive movements. So after cranial nerve, after motor system, now reflexes. Planters, how are the planters? They were extensor. How are the DTR? DTR normal except DTR means deep tendon reflexes. They are normal except knee and ankle jerks are brisk. So that means they are exaggerated. They are very brisk. And coming to primitive reflexes, atonic neck reflex is still present. Asymmetric tonic neck reflex is still present. And glomerular tap, blink response passes, and no abnormal movements. All other systems are normal. So no abnormal movements, no pyramidal tract, extrapyramidal movements, nothing is there. So they are all normal. And so what is your provisional diagnosis? So other systems were normal. One more thing is other systems. CVS was normal. Respiratory system was normal. So CVS S1 S2 was had. No murmurs. Respiratory system, bilateral airway was equal, good, and normal vesicular breath sounds, and no abnormal sounds. And coming to per abdomen, it was soft. There was no any organomegaly, and balls also were had. So other systems were normal. So with this examination, after your history, after your exam, before going to investigations, after your history and after your examination, you have a provisional diagnosis. So the provisional diagnosis will be, it's a case of cerebral palsy. And what kind of cerebral palsy? It's a spastic cerebral palsy. Okay, because there is tone is increased, reflexes are brisk, and resistance to passive movements is increased. So it is a case of spastic cerebral palsy. Your diagnosis should be complete with microcephaly, with facial nerve palsy, with global developmental delay. So this will be your complete diagnosis. So it's a case of spastic cerebral palsy, and if you compare this cerebral palsy also, which were more involved, lower limbs were involved, upper limbs were almost spared. So it is a spastic diplegic CP, cerebral palsy. So the complete diagnosis is spastic diplegic cerebral palsy with microcephaly, with facial nerve palsy, with global developmental delay. This will be your complete provisional diagnosis, which we will discuss next. So what investigations would advise? So MRI scan, ophthalmic examination, hearing test, speech and language evaluation, and EEG. So these are the tests you need to get done. MRI scan to look for how is the extent of the injury, and ophthalmic examination to rule out any other probabilities. Hearing to assess the hearing, and speech and language to further advise what modality of treatment is required, and EEG to know what kind of seizure activity is seen. So coming to the discussion part. So this is a case of cerebral palsy. Cerebral palsy is a group of non-progressive and non-contagious disorders causing physical disability. So it is non-progressive and non-contagious. It does not spread, but there is a severe physical disability. It is a group of permanent disorders of development of movement and posture causing activity limitation. So child is limited. So it's a morbid disease. So 75 to 80% of causes of cerebral palsy point to antenatal factors. So most of the times, if you look at these cases, if you take a detailed history, somewhere problems lies in the antenatal or natal, leading to abnormal damage of the development because of the damage to the brain. So somewhere there is a damage. So in this case, if you see, child did not cry at birth, child had some ischemic episode at birth, and child throat seizures also at the in the NICU in the initial days. So this was the insult which has happened. So main etiologic factor in 10 to 20% of children with CP. Main etiological factors in 10 to 20% of children with CP are intrapartum asphyxia and exposure to metal infections and fever. But if you take in this case, it was intrapartum asphyxia and not the metal infections, because we have ruled out. There was no tox infections. Mother did not have any fever. Mother did not have PROM. Mother did not show any leaking PV. Mother did not develop any fever during pregnancy in the first trimester or before delivery. So these are the common things. And child had intrapartum asphyxia, that is perinatal asphyxia alias birth asphyxia, which led to CP later on in the life. So prematurity, especially infants weighing less than 1 kg, is a major factor resulting in intraventricular hemorrhage and periventricular leukomalacia. Yes, this is also cause of cerebral palsy, but in this case it was a perinatal asphyxia. So clinical features, most common presentation is delay in motor development such as head control, sitting, standing and walking, which was there in this case. All type of CPs are characterized by abnormal muscle tone, reflexes are motor development and coordination. So there is tone is abnormal, reflexes are abnormal and development and coordination is poor. And associated malformations include delay in speech, visual difficulties and intellectual disabilities and seizures, which all were there in this case also. There was delayed speech, there is visual difficulty, there is intellectual disability and seizures. So all these are associated manifestations of the CP apart from motor involvement. So classification, yes, I already told you, spastic cerebral palsy, and it accounts for 70% cases. And again, it is divided depending on the involvement: spastic diplegia, hemiplegia, quadriplegia, monoplegia, triplegia. See, name only will tell you. Triplegia means 3 limbs are involved. Monoplegia means 1 limb is involved. Quadriplegia means all 4 limbs involved. Hemiplegia means one-sided, that is either right side upper limb and lower limb or either left side upper limb and lower limb. When you come to diplegia, it means lower limbs are more affected or only affected compared to upper limbs. So either upper limbs can be spared or upper limbs are slightly affected, but lower limbs are predominantly affected in spastic diplegia, which was in this scenario. So here the diagnosis of this scenario was spastic diplegia because lower limbs were more affected. So it was a spastic diplegic cerebral palsy. But if the upper limbs are more, affected more, then we call it as double hemiplegia. So lower limbs more affected, it is diplegia. So this was a case of spastic diplegia. So name only will tell you. So again, there are other types apart from spastic: dyskinetic, mixed, ataxic, hypotonic. Dyskinetic, they have extrapyramidal symptoms. It may be athetoid movements, abnormal movements they'll have, athetoid, chorioathetoid, this kind of movements they'll have. So it is dyskinetic cerebral palsy. And mixed means, yes, again mixture of everything. Ataxic, yes, name only is telling you. And hypotonic CP. So these are the 5 varieties: spastic, dyskinetic, mixed, ataxic and hypotonic. And most often 70% is spastic cerebral palsy. And what case we have discussed was a spastic diplegia, because the lower limbs are more affected than the upper limbs. So what are the differential diagnosis? So differential diagnosis, yes, you should try to differentiate from the degenerative disorders, neurodegenerative disorders, because there was no regression of milestones. Neurodegenerative disorders, there will be regression of the attained milestones. Child will normal at birth with normal antenatal history, with normal natal history. At birth also child will be normal. Baby will cry, baby is shifted to mother side, and postnatal history is normal. And later on milestones also with normal till certain extent of age, from where there will be regression of the attained milestones. Let me child will have attain normal head control at 3 months, normal rollover at 6 months, normal walking at 1 year, but later on he will regress one milestone which he has attained. So this is a very peculiar specific feature of the degenerative disorders. And what about myopathies? Myopathies, yes, specific muscle involvement will be there. Muscular dystrophies, yes, it will be muscle weakness in the concerned muscles. And spinal cord tumor, they will have focal deficits. So these are the differential diagnosis. And management, yes, it's a multidisciplinary approach which includes pediatrician, which includes physiotherapist, occupational therapist, orthotic specialist, orthopedic surgeon, psychologist, education specialist, speech therapist, social workers along with consultants, and consultants in neurology, psychiatry, ophthalmology, assistive technology, and otorhinolaryngology specialist. So it is a team of multiple doctors, multiple specialists are required depending on the problem. So example, pediatrician is mandatory, but if the child is having severe orthopedic problems, the tendon releasing technique should be done. So for that he may require orthopedician, and for regular exercise he may require physiotherapist. If there is any hearing defects, yes, a ENT doctor. Similarly, all specialists, education specialists especially, and counseling, motivating doctors, everybody is required. So it is a multidisciplinary approach. So counseling the parents, trying to explain them the reality, and the drugs, muscle relaxants like leoresil, baclofen, dantrolene sodium, and benzodiazepines, because there is severe spasm. So spastic CP, there is a severe spasm, so you need to give muscle relaxants, and if it is not controlled with that, sometimes yes, surgery also can be done. And to relieve spasticity, botulinum toxin. So locally we give botulinum toxin to that particular muscle, so there is a relieving of the spasm. And the levodopa and carbamazepine are recommended in dystonia and rigidity. So in dystonia and rigidity, we use levodopa and or carbamazepine. So approach is a multidisciplinary approach where multiple specialists are involved depending upon the problem, and counseling of the parents regarding the condition and regarding the support what they need to give. And drugs, yes, mainly drugs are diverted are to treat spasticity. Various drugs such as lioresal, baclofen, dantrolene, and benzodiazepines, and sometimes botulinum toxin locally also we need to give. And levodopa and carbamazepine drugs are involved in dystonia and rigidity. So management, surgical procedures such as tendo Achilles lengthening, adductor tenotomy, psoas transfer, and soft tissue